welcome to Medical Grand Rounds. I just want to give everybody a reminder to please come join us next week for one of our absolutely favorite Grand Rounds of the year. Our internal medicine residents will be presenting some of the finest cases out of St. Vincent Hospital, as well as our clinic, and their quality improvement and research projects as well, in preparation for doing presentations at the Oregon ACP meeting next week. So please come support them and learn lots. Today, I'm delighted to introduce Dr. Brandon Jones. He's a practicing interventional cardiologist, including work with our valve clinic here at St. Vincent's. Dr. Jones earned his medical degree from Boston University, went on to do internal medicine residency at Massachusetts General Hospital in Boston, and then later his fellowship in cardiovascular medicine as well as interventional cardiology at the Cleveland Clinic. Dr. Jones maintains interest in research. He has published multiple peer-reviewed studies as well as book chapters, and we really appreciate him joining us today.
All right, well, thank you very much, and appreciate the opportunity to come and be with you guys today and talk a little bit about something that takes up a lot of my focus and thought, which is aortic stenosis. I didn't know if I had to make disclosures, but I don't get any direct financial reimbursement from industry. I am going to discuss some off-label usage of some devices, and I'm still pretty new here. It's probably my biggest disclosure. A lot of what I'm going to talk about with regards to the Providence Valve Center has been built by my colleagues who've been here over the last decade or so, and so much of what I'm going to talk about is their work. So we'll talk a little bit about aortic stenosis in general, quickly move on to transcatheter aortic valve replacement. You might see TAVR or TAVI used interchangeably. One is replacement, one is implantation. The Europeans say you're not really replacing the valve, you have to call it transcatheter aortic valve implantation, but in the United States, we've been still saying TAVR. Talk a little bit about where we are in 2018 with transcatheter valves. Specifically focus a bit on difficult vascular access and some stuff that we do here that's unique with regards to transcarotid TAVR. Talk some specifically about stroke prevention. Introduce you a little bit to the rest of the team. And then if we have some time, I'll talk a little bit about some new novel mitral things. We'll see how quickly we can go. So what is aortic stenosis? It's narrowing of the aortic valve. It occurs over time, whereby the valve degenerates due to calcium and lipoprotein deposition, and there's likely a chronic inflammatory component of the disease process. And this is just a very basic representation of a normal valve with 3 cusps that opens and closes, and here's a scarred valve, whereby the commissures, which is the part where the valve leaflets meet, get calcified and they don't open. The process by which this happens is most often degenerative, and that happens in older patients, typically older than 70 years old, and that's this gradual inflammatory process. But you can also have much younger presentations, either from rheumatic disease in very young adults, bicuspid disease, or other congenital abnormalities of the valve cause it to degenerate at younger ages, and you can even have a unicuspid valve where there are no cusps, and those fail very early. 2-leaflet or bicuspid valves come in different variants. This is a picture from the Sievers paper, and the classification system is named after Dr. Sievers. And the type 0, which is a true congenital 2-leaflet valve, is less common than what we see here, which is a 3-leaflet valve with a fused raphe or commissure here. And that's by far the much more common type. But this is what we usually see in our sort of 50 and 60-year-olds who present with aortic stenosis earlier. This is a paper from the Lancet just talking about overall prevalence of valve disease. And again, what you see is it's uncommon in young patients for aortic stenosis to present. But once you get over the age of 65 and 75, we think it occurs in about 2 to 4% of adults. And here is the 1968 Eugene Brunwald picture that we all learned in medical school. Even those of us that went to medical school recently still have to learn this picture. And basically what it says is that there's a long latent period where there's severe aortic stenosis, and it's asymptomatic. And then at some point, there's an onset of symptoms, and you've got the three things we all learn. You can either have angina, you can pass out, or you can develop overt heart failure, and your survival depends on the severity of those symptoms. It's important to note that there's about a 50% predicted survival at 2 years among patients with severe symptomatic aortic stenosis, but occasionally we get referred a patient in the valve clinic where the aortic stenosis was incidentally found on the echocardiogram, and a physician says, you'll be dead in 2 years if you don't get this fixed. And it's important that we note that asymptomatic aortic stenosis doesn't always require emergent therapy. Diagnosis is mostly echocardiographic these days, not to diss the stethoscope. This is a parasternal long axis view of the heart. So this is your left ventricle here. This is the aortic valve, and the blood gets pumped out through the aorta, and this valve opens very nicely here. This is a stenosed valve on the other side, and you see it's very calcified. There's a lot of shadowing, and it doesn't open. And when you put color Doppler on this, you see a lot of turbulence in the aorta from the stenotic valve. And the turbulence is because as the orifice narrows, the velocity at which the blood shoots out of that gets much faster, just like when you put a nozzle on a hose, which is how I explain it to a lot of patients. So a quick case. This is a 73-year-old woman who was admitted to Providence, Portland in June. She had a history of diabetes, hypertension, hyperlipidemia, psoriasis, and asthma. And she developed progressive shortness of breath and ulcers on the legs. And this was attributed to her long history of asthma and her psoriasis. And she was started on daily inhalers. But she didn't get that much better, and she was ultimately admitted with respiratory failure. And this was her echocardiogram. And what we see here in a short axis view, so we're looking sort of down on the valve, is that this cusp here is fused, and there's minimal movement here, and then this is the small orifice with the valve barely opening on this side. This is now an apical view, so from the side of the chest here, looking up at the heart, and so the ventricle is on the top of the screen. This is your aortic valve, and what you see is there's turbulence as the blood gets pumped out of the heart, and there's also regurgitation, this jet coming back in towards the ventricle. And so how do we quantify it? So we use a Doppler assessment, and you compare the velocity through the LVOT, which is the outflow tract here, to the increase in velocity across the whole valve here. And this is quite severe aortic stenosis. What you would hear when you listen to this woman is a late peaking severe murmur, her loudest sort of in the area of the right upper or left upper sternal border. And less severe aortic stenosis, this would peak earlier, and you wouldn't have such a high jet. So the peak velocity here is almost 6 meters per second. The mean gradient is nearly 90 millimeters of mercury. We quantify severe aortic stenosis as mean gradient over 40, a peak velocity greater than 4 meters per second. And then you can calculate a valve area based on the diameter of the outflow tract. But that calculation is a little more prone to error. So we tend to rely on the gradient and the peak velocity mostly. So she was unfortunately found to have very severe aortic stenosis. Her ejection fraction was depressed. She had bilateral pleural effusions, had to get those drained percutaneously. And it seemed like her wounds of the legs were actually a combination of arterial disease, and she had venous stasis ulcers, and these weren't healing at all. She had coronary angiogram, and it's a little tough to see, but she has a severe stenosis here in the proximal right. Most of her arteries look okay downstream, but she's got a critical stenosis here right in her left main artery. So she needs an aortic valve replacement, and she needs a multivessel coronary artery bypass surgery. And we had her seen by our excellent, aggressive, and not shy fantastic surgeons, and they were very scared to operate on this lady. When you look at all of her comorbid conditions and you plug it into an STS calculator, she's got a 1 in 10 chance of not surviving the surgery, nearly 50% chance of morbidity and mortality, 4% chance of stroke. And this is just a calculator, it's not perfect, but what our surgeons came back to us and said was her risk is actually much higher than this based on how sick she is right now, bilateral pleural effusions. So they didn't think she would survive a surgery. And so fortunately, in 2018, we had the option of replacing her valve with a transcatheter valve. And this is a balloon expandable transcatheter aortic valve, and we put this in via the artery in her leg, and this was her procedure. You know, in this case, we actually didn't treat the coronary arteries because she wasn't having angina, but we did end up having to open the arteries in her legs to get her wounds to heal. So we were planning on maybe doing her coronary arteries down the road if she had angina, and she hasn't come back with angina yet. So why transcatheter aortic valve replacement? Outcomes with surgical AVR have always been universally fantastic. Why do we need another way to replace the valve? And the problem is at least 30% of patients with severe symptomatic aortic stenosis have historically not undergone surgical AVR, and that's a combination of comorbid conditions or just being thought to be high risk. So 3 out of 10 people aren't offered the procedure. Medical management is universally futile, so you can give patients diuretics. It helps symptoms temporarily, but it's never been shown to improve survival. This is something we used to do a lot of. This is a balloon aortic valvuloplasty, and we thought, well, if you stretch the valve open, you can relieve the obstruction, and maybe people who don't have an option for surgery, this will help them. And people feel better for about 6 months, but the stenosis almost always comes back, and it's never been shown to improve mortality. So this is the PARTNER 1 trial, and this was one of the most revolutionary sort of pieces of cardiology literature in the last couple decades. And basically what they did was they took people with severe symptomatic aortic stenosis, and they divided them into 2 cohorts. One is patients who were deemed inoperable, and one was patients that were deemed to be very high risk for a surgery. So the cohort A is people who were operable but STS score greater than 10%, and cohort B were people where the surgeon said their chance of making it through this is less than 50%. So PARTNER 1B, the inoperable patients with severe symptomatic aortic stenosis, they had an average STS score of 11%, so not that much higher than the patient that I just showed you. And what they found was if you randomize these patients to transcatheter aortic valve replacement as opposed to medical management only, there was a 20% reduction in mortality at 1 year. Out to 2 years, and this curve actually goes all the way out to 5 years now that we've seen this. And so this paper came out when I was a second-year resident at Mass General, and everybody during your second year there has to present one piece of literature at the noon conference there. It's a big deal, and you spend a lot of time figuring out what paper you're going to do. And this came out right around that time, and I presented this paper, and I was just floored by this. I mean, a 20% reduction in mortality in a group of patients this old and this sick was basically unheard of. And this is, you know, basically what made me want to go into interventional cardiology, because I wanted to do this. This was the other arm of the trial. This was the high-risk patients, and these were randomized to surgery versus transcatheter aortic valve replacement. And what you see was the mortality was equivalent in the 2 groups. So there were some important things that came out of this study, and I'll just highlight the major ones. So bleeding was better with transcatheter valves versus surgery. That makes sense. There were more vascular complications, though, with the transcatheter valve, and this first-generation valve was very large. There was a signal for more strokes in the transcatheter valve arm as opposed to the surgical arm in this first trial. And there was more paravalvular leak. So you imagine a surgeon goes in there, cuts out the old valve, sews in a new valve, and you get a very nice result. And there's no leak around that valve. You got this nice sewing ring. With transcatheter valve, you have bulky calcification. So that valve goes in, and there's irregular pieces of leaflet that are pushed out on the side of that valve, and it can leak a little bit around the side. And nobody thought that would be much of a problem. You know, people have mild aortic regurgitation, and you know, some people with severe aortic regurgitation don't really have any problem. We were surprised that paravalvular aortic regurgitation was such a big deal. And this is a paper I worked on when I was a fellow, and we looked at, of all of our first-generation valve patients, we split them up based on the degree of aortic regurgitation and their mortality at 1 year. And these are mild degrees of aortic regurgitation. I mean, there were only 4 patients with 2 to 3 plus, which is still moderate to severe. These are moderate aortic regurgitation patients. And these are all considered degrees of mild aortic regurgitation. And there is a very significant stepwise increase in mortality based on even milder levels of aortic regurgitation. Fortunately, over time, the valve has been developed to have less aortic regurgitation. And in subsequent trials, this signal for mortality has only held for patients that have moderate to severe paravalvular leak.
What's their expected mortality?
The expected mortality, well, you would say in the first generation partner cohort was 50% at 1 year, because that's what the control arm did. So we learned from partner 1 there were more vascular complications with TAVR, more paravalvular leak. There are more pacemakers because the valve goes into the part of the LVOT where the bundle of His runs. We thought there were more strokes, although all the subsequent trials fortunately showed that the strokes were equivalent between TAVR and surgery, and some of the more recent trials show that it's actually less with transcatheter valves. So that was a bit of an anomaly that fortunately didn't hold up. But when you looked at this original trial, even these high-risk patients, health status, quality of life were improved with transcatheter valves as opposed to open heart surgery. And it was shown to be very cost-effective, even though the devices were initially quite expensive. So there was a lot of excitement over this sort of first effort. The devices were designed to be smaller. So this original device was 22 to 24 French, which means it's an 8 millimeter in diameter sheath. And that was made much smaller over subsequent generations, and that's responsible for a big reduction in vascular complications. They were designed to have less paravalvular leak by putting skirts on the valve. They were designed to have less pacemaker risk, and part of that is we learned to implant the valve a little bit higher so it doesn't compromise the conduction system as much. They were designed to be repositionable, so you could put it in, check the position, recapture it, put it in again. And so now here is all the different valves we have available. So this was the original one from the partner 1 trial. That's version 2. Version 3 is the S3 valve, and that's what we're putting in about 80% of our patients here currently. The core valve was the next one to gain FDA approval in the United States, and this is the second, and there's now a 3rd generation core valve also. And that's a self-expandable valve, and I'll show you an example of how that goes in just a second. The Lotus valve is a valve made by Boston Scientific, which the valve team here was a part of the pivotal US clinical trial for. And this is the Centera valve, and I only highlight this because it's coming to US clinical trials at the start of the next year, and we'll be involved in that trial as well. So this is a core valve. And this is a self-expanding valve, so opposed to the balloon expandable valve, which is crimped down on a balloon, and we implant it by inflating the balloon, this one gets unsheathed. And so you see it's partially unsheathed on the image on the right. And at this point, on the image on the left, it's still recapturable. So we're taking a picture to make sure that we like the spot that it's going in, and then you finally release it. And also the technology was tested in lower risk populations. So not to highlight every single clinical trial that's been done on TAVR over the last decade, but these are the pivotal ones. And so all the way over here on the left is the original partner trial. And as you go across, these were high risk trials. Generally speaking, STS scores greater than 8%. These are all the trials for intermediate risk populations, roughly STS score 3 to 8%. And there are even low-risk trials. St. Vincent was part of the Partner 3, which is the low-risk United States pivotal trial, and that trial has completed enrollment. We're still, we have continued access registry availability for patients that are low risk that qualify for that trial, and we have a bicuspid registry that's still open for that trial. But those results are expected within a year, and we'll see what that shows. But if you look at the blue bars here, this is 1 year mortality. And what you see is over time, as the technology has been applied to lower risk populations, we've had just continually declining mortality rates. So the technology has really improved and been applied to wider groups of populations. And you see that in the STS data. This is 2016 a report on the STS database, and what you see here in the blue line is isolated AVRs, the yellow line is AVR and CABG, and the red line is transcatheter aortic valve replacements. And in 2016, for the first time, there were more transcatheter aortic valve replacements done in the United States than there were surgical valves. So this is the Providence Valve Center at the beginning. You probably see a lot of familiar faces here. Started in about 2012, and the reason why the Valve Center started is because they were invited to participate in the intermediate risk trial for the SAPIEN balloon expandable valve, and St. Vincent's was one of the top 10 enrollers for that trial, and Dr. Hodson, my colleague, was an author on the New England Journal paper. And what this one showed, just to highlight this trial because it's a point of pride for the team here, is that if you had a transfemoral TAVR compared to open heart surgery, there was actually a mortality benefit in intermediate risk patients. The mortality benefit didn't hold up as much as if you had to have access through the side of the chest or some other alternative access route. But if you could do it from the leg, you had a mortality benefit as compared to surgery. So now they're on to their 500th TAVR. And today we've done over 1,200 of them. We currently perform about 350 of them a year, and it's becoming somewhat routine for us. How did it grow so fast? Well, it became safe and effective for intermediate populations, and that opened it up to a lot of people. Most of the procedures are done under conscious sedation, so 95% of the time we don't need to put a breathing tube down. More than 90% of patients can be done from the femoral artery now, and that's because the sheaths have become much smaller. We talked about the mortality benefit for intermediate risk patients. So generally speaking, we steer intermediate risk patients who don't have complicated surgical anatomy otherwise towards transcatheter valves now. I will say the long-term durability of the transcatheter valves is still a little bit unknown. So we've only been putting this third generation valve in for the last 4 years or so. And the original patients from the original trial were all in their late 80s and were extremely sick, so they didn't survive longer than 5 years anyway. So before we consider, or if ever consider, putting the valves in much younger patients, I think that needs to be sorted out. The low risk trial, so STS score is less than 3% that just finished enrollment. I assume the average age of patients in that trial is still going to be in the upper 70s. So these are low risk patients, but older age patients. So how do we limit vascular complications? Well, we talked about smaller devices, but there's still a lot of patients who don't have adequate femoral anatomy. What are our options? So you can go from the femoral artery, which is our preferred approach. You can come from the arm, and you can get to the axilla or the subclavian surgically. You can go directly into the aorta, and we actually did this for a while as one of our preferred routes during fellowship. Originally, we thought this was all going to be done through the apex of the heart. So you avoid going on cardiopulmonary bypass, but you still make a big surgical incision. You go straight through the apex of the heart, and you put the valve right in, and then you stitch up the apex of the heart. We've almost completely abandoned this because there's always another way at this point. I can't think of the last time we did this, but outcomes are worse with transapical TAVR compared to other routes. So here's an example of a patient who's got very severe calcification in the iliac arteries, and this is an example of the CT reconstruction that we get for every patient. So this is the aorta, this is the internal, or the common iliac, this is the external iliac, and the femoral artery down here, and you see up here in the common iliac, we have a 2 millimeter vessel, circumferential calcium. There's no way we can do a transcatheter valve from this person's femoral artery. So at St. Vincent's, we do it from the carotid artery. And this is something that the team here pioneered. There's a group in France that does quite a few transcarotid TAVRs, but in the United States, we do more of them than anyone. This is a paper that was published by Dr. Kirker and Dr. Hodson and the rest of the team here showing our approach and the results from our first 30 or so patients. And basically, we get surgical access to the neck. We put in a sheath, just like we would put a sheath in the groin. This is the TAVR sheath then going into the artery in the neck. The way we ensure that it's safe to do this is we clamp the artery and we put a needle in and we check the pressure backwards through the circle of Willis. So as long as we have a pressure of 40 millimeters of mercury after clamping the artery, we think that the circle of Willis is complete enough to backfill the rest of the brain. And when we're done, take the sheath out, repair the artery. We back bleed before we repair the artery to make sure any debris that might have come loose doesn't go up towards the brain. And I thought this was crazy when I came here and interviewed. We'd never done this in Cleveland Clinic. And we had talked about doing it, and we're like, it's crazy, everybody will have a stroke. Why would you go into somebody's carotid artery? And I started doing some of them with Dr. Kirker when I got here, and I still thought it was a little crazy initially. And then we did more and more of them, and it takes us the same amount of time as a transfemoral TAVR. So 75 minutes instead of 71 minutes on average per case. The length of stay is the same, and most of our patients now, I mean, this is from a couple years ago, most of our patients now go home either the next day or the following day after their carotid TAVR. Nobody had a stroke. And there was only one mortality at 30 days. We have data now from our first 90 patients that we did. We've done more than 100 transcarotid TAVRs now, and we're going to publish that data soon. But none of our first 90 patients had a stroke. And the reason is you control the cerebral circulation while you do the procedure. So as long as you're careful about analyzing the carotid ultrasound ahead of time and looking at the CT and make sure that you have a healthy artery there, the outcomes are universally fantastic. So we do 4 of these in a day. Dr. Kirker and I did 4 of these all on the same day a couple weeks ago, and it's really revolutionized our alternative access TAVRs, and we get sent patients from all over the state for this specifically. So speaking of strokes, so I said there was a signal for increased strokes for TAVR as compared to surgery in the initial trial. So that's been a real hot button issue for the rest of the literature. What's the mechanism for a stroke? So if you have a stroke during surgery, it can be from a variety of issues. It can be cardiopulmonary bypass, so-called just general hypoperfusion watershed injury due to low oxygen saturation during cardiopulmonary bypass. There can be air emboli. There can be embolic debris. There's a variety of things, and it's been very difficult to reduce strokes in surgical procedures over time. But all the strokes, just about, that happen during a TAVR are embolic. And it's because when the valve goes in or the equipment goes across the arch, we can liberate debris from the calcified aortic annulus. So if they're all embolic, can we come up with ways to prevent them? So here's a 75-year-old guy, prior bypass surgery, atrial fibrillation, hypertension, and severe aortic stenosis. And he had an embolic stroke just during his diagnostic coronary angiogram. He actually came back to the hospital and was lysed the same day as his angiogram. Fortunately, he fully recovered, but he came and saw us in valve clinic, and he's scared about having another surgery or another stroke during his TAVR. So what are our options for preventing a stroke during a TAVR? So here's a case that we did during fellowship, and we were facing a similar situation. So this patient had a mobile atheroma on the valve and in the ascending aorta, and we're going to put a valve in here. And we were scared. You know, this thing's going to come loose while we're doing our TAVR. This patient wasn't operable either. And so what we did was we put a sheath in every artery in the patient's body. So that's the left hand, that's the right hand. There's 3 on the right groin, 2 on the left groin. And we put a filter wire in the right carotid, filter wire in the left carotid. We inflated a balloon in the right subclavian, inflated a balloon in the left subclavian, and then went and put a valve in, and then took all that stuff out of the body. And it makes you say there's got to be a better way, right? But that's all we had available to us. So embolic protection devices are now something that have been developed over the last decade. And these are the only 4 that have made it anywhere. This one now was abandoned by Edwards. This is a cannula that was used during surgery. It's an aortic cannula used for cardiopulmonary bypass that has a little net on it. This one's also been abandoned. So we're left with 2. This is called the TriGuard device, and it sits across the arch vessels and just sort of shoots everything down towards the legs. And this is the Sentinel cerebral embolic filter. And so we'll talk a little about the Sentinel, because that's the only one that's made it to FDA approval. And so it sits one filter in the innominate artery to protect the right carotid, a second filter in the left carotid, and you don't protect the left vertebral, but you get the rest of the circulation. So there were 360 patients randomized to protection versus control, and they looked at MRIs after these procedures, and they had a very vigorous stroke adjudication by a neurologist. And what they found was, on average, well, first of all, what we found during all these trials is a lot of people have subclinical strokes during TAVR and surgery, and we weren't picking up on them. And so the volume of the new lesions by MRI was much bigger if you didn't get protection as opposed to using the filter. Numerically, there were many more strokes, almost twice as many, in the patients who weren't protected. And we pulled something out of the filter 99% of the time. Now, that didn't meet statistical significance for clinical stroke reduction, and the reason is that strokes are still relatively rare. This is a subsequent trial that was done in Europe for cerebral embolic protection, and this is not randomized, but it is prospective, and what they found in this trial is that there was a reduction in mortality and stroke if you used the filter compared to if you didn't protect the patients. So this went to the FDA, and the FDA said, well, the trial was a little underpowered, but it's pretty clear all the studies are showing about a 70% reduction in stroke, and if you did a TAVR on any of us, we would certainly want the filter. So they all voted to approve it. It's been slow to get adopted because there hasn't been any reimbursement for it yet, but as of the beginning of October, there's a specific add-on code for Medicare payment. So this is what we did. We put one in. So we protected this guy during his TAVR, and this is a picture of the device going in. So again, you deploy one filter in the innominate, and then this thing goes down. You have to curl it up, and then you have to wire into the carotid artery, and then you send the second filter up. And it looks complicated, but after you've done a couple, it's actually quite easy to do. So we're very proud that we were the first hospital in Oregon to employ this device in a patient. So I introduce you to the Valve Center, and then maybe I'll spend just a couple minutes on mitral stuff, because that stuff's exciting too. So there are 3 of us interventional cardiologists that perform the structural procedures here. All of our surgeons are involved in the transcatheter procedures. And Lisa and Elizabeth are our fantastic PAs that participate. Lisa's been with the valve program since the very beginning, and Elizabeth came on to help out with valve stuff as the volumes grew. This is a picture in the valve clinic, and this is just to show you what a multidisciplinary experience it is when the patients come through the valve clinic. So these are our nurse coordinators, Holly and Lori, and they're the patients that help they're the coordinators that help get the patients triaged and screened and get all their tests, and they're the ones that you would communicate with if you're referring a patient to the valve clinic. We always have an interventional cardiologist and a cardiac surgeon in the valve clinic. Palliative care is integrated into our valve clinic. Many of our patients are elderly and sick, and some patients are too sick for any sort of intervention. And so our palliative care team is fully integrated in both our valve clinic and our multidisciplinary discussions that we have on Wednesday mornings. And there's Lisa. But that's just the tip of the iceberg. Brenda, our program manager. Marla, who's been with the program since the very beginning, is now focusing mostly on inpatient needs for our patients. We've got a team of dedicated cardiac anesthesiologists, a team of dedicated cardiologists who perform echocardiograms during these procedures, Dr. Zink, Dr. Whetstone, the team of cardiac imagers that do CT and MRIs, our staff in the CVORs, our fantastic hospital medicine team who bear the brunt of the inpatient management of many of these patients, and our research team. So we have 8 dedicated research staff who help navigate our patients through the various options when there isn't a commercially available option for them. So these are complicated patients. They're often very old. They have many comorbid conditions. They really require a multidisciplinary approach. And we meet every morning from 6:30 to 8 in the morning to review cases. And that's always a busy, lively meeting. So Should I stop and take questions about aortic valve disease? I was going to show a couple mitral things. Or push on? All right, this is off topic, but I love the mitral valve too. So I'm just going to talk a little bit about mitral valves. So everybody knows what the mitral valve is. This is now the one that accepts blood from the lungs, and it has to close when the heart pumps blood out to the body. If one of the leaflets is bent back in the wrong direction, that's called degenerative mitral regurgitation. When the annulus separates because of a sick ventricle, that's called functional mitral regurgitation. So degenerative is a problem with the valve itself. Functional, we think, is more of a problem with the ventricle, and the leaflets aren't coming together. So mitral regurgitation is truly an unmet need. This is a paper that one of my co-fellows did when they were at Cleveland Clinic. And what you see is that as much as 53% of patients at the Cleveland Clinic over the course of I think they looked at about 10 years here, with severe mitral regurgitation didn't go through any sort of surgery for that valve. And it was a combination of factors. Either it was functional mitral regurgitation, which has never really been shown to have a good surgical fix, or they were too old, or too many multiple comorbid conditions to have a procedure. But what you see is there was a very high mortality over 5 years in these patients who didn't undergo intervention, and they were hospitalized quite frequently. This is the mitral clip. So the mitral clip is a FDA-approved device that goes into the vein in the leg, and we go up towards the heart, and we do a transeptal puncture. So we puncture from the right atrium into the left atrium with a needle. And this allows us to get access to the left atrium just above the mitral valve. And we bring a large sheath into the left atrium, and then we're sort of staring down at the mitral valve from above. And what we do is we come in with this, it's kind of like a clothespin device, and it's steerable. And you come down to the valve, and we do this all under transesophageal echocardiogram guidance. And you can turn this thing, and you can open the wings up and down. It's got these grippers on it that help it close onto the valve. And you go underneath the leaflets, and you lift it up, and you try to catch them both. And then the grippers sandwich the leaflets down, and you close this thing, and you deploy it. And what this was designed after was a surgical procedure by a surgeon named Alfieri, who in Italy used to, rather than do a typical repair, he would sew the leaflet shut in the middle. And you still have two orifices on the outside, so the blood goes through, but when the heart squeezes, it's pinched in the middle. So here's an 83-year-old female with severe mitral regurgitation. She had a long history of mitral valve prolapse, but now she's got atrial fibrillation, and her regurgitation is severe, and she's got swelling in her legs, and she's short of breath. And she was felt to be extremely high risk for surgery due to age and just general deconditioning and a poor likelihood of rehabbing after a sternotomy. And what you can see here on a transesophageal echocardiogram is there's a severe jet of mitral regurgitation. And you see over here on this side that the posterior leaflet here is prolapsing back into the atrium. So this is a picture of the procedure, and she ultimately needed 2 clips, and that's not uncommon. You put one next to the other, and here's her pre and post echocardiogram. So we were able to get her mitral regurgitation knocked down to trivial to mild. Functional mitral regurgitation is really the true unmet need, though. So degenerative mitral regurgitation does very well with surgery, but there's never been a trial that showed that surgery for functional mitral regurgitation helps. And it might be because the problem is the ventricle and it's not the valve. Or maybe the valve is part of the problem, but the surgery is too invasive. And going through a sternotomy for somebody with a ventricle that's that sick, you spend your benefit of reducing the regurgitation by the risk of the surgery. And so the COAP trial was the pivotal United States clinical trial that randomized patients with functional mitral regurgitation to very aggressive medical management versus aggressive medical management plus the clip. And this was really aggressive medical management. I mean, these patients were in the trial for months and months and months we would have these phone calls, and we would say the patient is on, 30 of lisinopril, and the blood pressure is 105, and they would say, try 40 of lisinopril, and then call us back in a few weeks. So these patients are really, really aggressively medically managed. And this was just presented last month at our big interventional conference in San Diego. And we've been doing this trial for 5 years, and Providence was a trial site for this. And we didn't know what this was going to show, and everybody was sort of floored by this. So there was a very significant reduction in hospitalizations in patients who got the mitral clip as compared to the control group, and these were very aggressively medically managed patients. And the most shocking thing was there was a 17% reduction in mortality at 2 years in the patients that got the clip. And this reminds me a little bit of what we saw in the original partner trial, where we took patients that were so sick. I mean, again, this is a nearly 50% 2-year mortality for this group of patients, and we were able to knock that down by almost 20%. So it makes me wonder if we're approaching sort of if the next decade is really going to be mitral stuff. And there are lots of other options. So this is another clinical trial that we're participating in. It's called the CardioBand, and this is also placed through a transseptal puncture, and this tries to imitate the annuloplasty ring, which is what the surgeons put on, that cinches down the annulus, but you have to screw each of these little pledgets in and then tighten the thing up and try to shrink the size of the annulus. That trial is on hold momentarily because everybody's trying to digest the results of the COAP trial. The Carillon device is another annuloplasty device that we've been asked to participate in the clinical trial for. And this goes in through the coronary sinus, which surrounds the mitral valve. And it's a metal device that anchors itself in the sinus and then takes a shape where it shrinks the annuloplasty, or shrinks the mitral annulus. So another cool, novel design. This was original data from Europe, showed that it reduced heart failure symptoms. So we'll see how that does in the clinical trial. What about just replacing the valve? So that has been more difficult than the aortic valve, and the reason is the aortic valve has a nice structure that's elliptoid but nearly circular. The mitral valve is much more amorphous in its structure, much less symmetrical. There's just not as much structure around the mitral valve to hold something in. So to just go in and put a balloon expandable valve in the mitral valve is not as easy a problem to solve. Lots of approaches have been thought of. Most of the valves to this point have been through the apex of the heart, just like the original aortic valves were. Might there be a way to do it from the septum, the way that we do the mitral clip? So here's the first patient that we did. So a 79-year-old gentleman. He had prior bioprosthetic AVR and MVR in 2002 with Dr. Jeff Swanson here at St. Vincent. And he now has severe bioprosthetic mitral stenosis, so mean gradient of 20. We usually consider severe to be more than 10. And he's got severe bioprosthetic aortic stenosis with a velocity greater than 4 meters per second. So both of his valves have become stenotic over time. He's not a candidate for a double valve redo operation because he's got severe pulmonary hypertension and his RV has started to fail. So what we did is we went in, and this is a transseptal puncture again, so we got across. So right atrium, punctured into the left atrium. We're ballooning open a channel in the interatrial septum. And then what we did is, this is a balloon expandable aortic valve, and we flipped it on the balloon so it opens this way instead of this way, and we put it inside his mitral valve. So this is transcatheter mitral valve and valve. And then we gave him a few weeks to recover, and then we came and we did his aortic valve too for good measure. This is one of the trials we've been asked to participate in for mitral valve replacement in people who don't already have a bioprosthetic valve. And this is Medtronic's version. It's called the Apollo valve. The trial is called the Intrepid. And they're trying to solve the question of, can you do this in somebody who doesn't already have equipment? And you see this design's got all these things on it to try to help anchor it in the mitral annulus. and it's still transapical at this point, but our hope is that they're going to have a transseptal version of this coming up soon. So we think maybe within the next 6 months to a year, we should have this available to our patients. There's other designs. So there's about a dozen different designs. I mean, this is a huge market, so every company is trying to solve this problem. So there will be transcatheter mitral valve replacement within the next decade that's a viable option. The goal, obviously, is to make it totally percutaneous. We eventually got away from transapical TAVR, and hopefully we will do the same thing for mitrals. Other cool stuff that's been done lately. So this is a tricuspid valve-in-valve. So same thing, a young woman who had a tricuspid valve replacement, and we replaced her valve a second time through the femoral vein. Might we be able to do a cardioband for the tricuspid valve? And then we're involved in FDA post-approval trials for PFO occluder devices as well. So thank you. I got to show a picture of my family. So those are my two kids, Hadley and Hunter, and my beautiful wife, Julia, who's a nurse practitioner here with Dr. Beamer, and so it was really fun. I got to give my first grand rounds. My wife got to come and watch. So thank you to them for their support through 8 years of postgraduate training. It was a long haul getting here, but I'm very happy to be here finally, and it's really a fantastic team and fantastic place. So we're very happy here. Yes.
This last case that you just mentioned, where the patient had both aortic stenosis and mitral stenosis, I'm just wondering, why couldn't you do the two together?
You could, and we talked about it a lot, whether or not we would do it all during the same procedure, or if we wanted to do one and then give the patient some time to recover and then do the other one. Ultimately, we just decided, let's take it one step at a time. And we also talked a lot about which valve you do first. So, hemodynamically, what happens if you relieve the aortic stenosis, but you still have severe mitral stenosis? We think that that's more severe. You have the suicide ventricle where it's underfilled, but there's no obstruction. So we talked about it a lot. It was our first one. We decided, let's do the mitral valve, complete that procedure safely. The aortic stenosis was less severe than the mitral stenosis, and we give the patient some time to recover and then come back and do the other one. But it's large bore venous access and large bore arterial access, so it doubles your risk of vascular complications.
I just have one more question. That you said that the device is now being used, the filters, to prevent the strokes, but the vertebral artery is still there. And is that being looked into? Is that still taking some muck up the brain?
So you don't cover the left vertebral artery when you have the device, and might you still have a stroke that just goes to the left vertebral artery? You certainly could, and some patients still have a stroke despite using the filter, and it's not even necessarily the left vertebral artery. There's a chance that you could dislodge some debris in the process of placing the filter. So we spend a lot of time making sure there's not calcium in the arteries before we put the filter in, make sure the anatomy is appropriate to use it. So it's not perfect, for sure, but the data now shows that it's about a 70% reduction in strokes across the board. The overall rate of stroke during TAVR is about 3%, and we've seen that that's been constant from some of the first trials until present day. And so if we can get that down to 1%, we think that's really meaningful. And yeah, it's not a perfect device, but it's pretty easy to use. The complication rate is almost zero, and so it's by far the best that we have right now.
Because you mentioned that 99% of the time those filters are caught. So that means there's a lot that's coming out.
99% of the time they catch something. And so, I caught a leaflet in one last week, a little piece of the aortic valve leaflet, but sometimes it's just a little bit of small muck. Whether or not that would cause a clinically meaningful stroke or not, it's always a little tough to say.
Thank you, great job.
Thanks very much. Yeah. So you can open and close it as many times as you want, and sometimes we do it. Yeah, so single leaflet detachment does sometimes happen. So you place the clip, we spend all this time making sure that you got enough leaflet in there and it's good grasp, but a small percentage of the time one of the leaflets will come loose. Both leaflet detachment and embolization of the clip is extremely rare. It happens less than 0.5% of the time. We have occasionally gone back in there and done an additional clip if the clip doesn't hold. We've occasionally gone back to our surgeons and said, hey, we tried really hard and it didn't work. Would you reconsider doing an open heart surgery? Sometimes when we put one clip in and we feel like we don't have enough tissue in there, we put a second clip in purely to stabilize the first clip. So we do a lot of stuff to hopefully prevent that from happening. Yeah.
So it sounds like going for the carotid approach was initially because sometimes you have complex anatomy coming up from the femoral. But now it sounds like you're kind of excited about it. So are you going to be doing carotid regardless of whether or not you can do femoral?
Yeah, I'm not sure that it would ever be preferable to a femoral TAVR. It's still surgery. It requires general anesthesia. We're gonna analyze our 100 cases that we did, and we're gonna do a propensity analysis compared to 100 similarly sick femoral patients that we did, and we'll see what the data shows. I think transfemoral TAVR is so good, it's gonna be hard for anything to beat it. But I think what would be important is to show the rest of the community who is still scared of the carotid approach that it's a safe alternative and certainly better than going through the apex of the heart or some of the other more invasive surgical procedures. If you can stay out of the thorax, so these subclavian approaches where you have to do a small thoracotomy, I think that really increases your risk of the procedure. But we'll see. Yeah.
Among patients who need a valve, an aortic valve, but also need CABG, do they always get a surgical valve, or is there some sequence that, what happens to those patients who are perfect for a transaortic valve in every way, except they need a CABG too? They just always get a surgical valve?
Yeah, assuming that the surgeons feel that they're good for the procedure, then they would get a surgical valve and a bypass surgery. And so I think if I can predict what's going to happen with the low-risk trial, I think it's probably going to show at least equivalence of TAVR versus surgery for low-risk patients. And then the question is going to be, well, who gets surgery? And I think the field is going to shift to, is this a good patient for TAVR? Right now we think about it, is this a bad patient for surgery? Okay, well, if it's a bad patient for surgery, can you do a TAVR? I think we're going to start to say, is this a good patient for TAVR? If not, because they have surgical coronary artery disease that requires bypass, or there's bulky calcium around the valve and we don't want to inflate a balloon there, or we can't get in through the legs, then we're going to say it's a bad patient for TAVR. We want to do a surgery on this patient. So if there's surgical anatomy, we always prefer to do that surgically. Yeah?
Is there any effect of mitral valve repair or surgery on pre-existing recalcitrant atrial fibrillation?
So the question is, does transcatheter mitral valve procedures affect atrial fibrillation rates? And I have not seen any data that shows that convincingly. We certainly use atrial fibrillation as a reason to go after mitral valve regurgitation, thinking that it's becoming more clinically significant. You would hope that reducing the regurgitation prevents some of the stress on the left atrium. I don't know any data that shows that for sure, though.
There's two things that will affect atrial fibrillation. One is untreated obstructive sleep apnea syndrome. The other is if the pulmonary artery is dilated beyond what the atrial orifice is, and that you would be in COPD. And I don't know if you're monitoring for pulmonary the dilation on the other side of the place where you're working, and whether you're looking at presence of obstructive sleep apnea syndrome, because that makes a huge difference in terms of the onset of atrial fibrillation. Cardiac EP docs are now extremely interested in that area. Are you?
Yeah, I agree with you completely. I think
Are they being monitored? Are they being worked up?
it admittedly has not been something that we have created initiatives for in the valve clinic, but I agree with you completely that untreated sleep apnea is a big problem, especially for that group of patients. Yeah, so bicuspid valves, the problem with bicuspid valves in terms of transcatheter valves is that often they occur in much younger patients where we're nervous about, are we going to do a 50-year-old and put a transcatheter valve in? If they're otherwise a good surgical candidate, they should have a surgical valve. They might even need a mechanical valve. And the rest of the anatomy is sometimes perturbed. So they're more likely to have a dilated aorta, which would be a reason why we would want to replace the aorta surgically also. Sometimes they're purely regurgitant. And so if there's not calcific disease, the valve doesn't hold. So pure aortic regurgitation is still an unsolved problem for transcatheter valves. So less frequently, they're anatomically suitable for transcatheter valves. But in older patients with bicuspid disease, we certainly have options when it's calcified, and there's a low-risk bicuspid registry that we have open for transcatheter valves. And we're doing one of them tomorrow, actually. So we do transcatheter valves for bicuspids. You have to look carefully at the anatomy. A true Seaver 0 2-leaflet valve requires a little more attention in terms of valve sizing. So there's some nuances to it, but yeah, we do them. Yeah, one more?
Basic clinical question. So, in your index patient who had severe aortic stenosis, as well as had a left main lesion, didn't have any angina? Is that correct?
Yeah, did not have angina, surprisingly.
Yeah.
And how is that? Yeah, I don't know. She had such severe shortness of breath and heart failure. And when we relieved the valve and she started going to cardiac rehab, she still didn't have angina. So it may be that the stenosis in the coronaries wasn't as severe. I ran a pressure wire down the left main and the right coronary artery, and it was significant on the pressure wire evaluation, but not horribly significant. So our threshold is 0.9 for the fractional flow reserve ratio, and hers were like 0.87. So it may be that her coronary disease, I think in retrospect, we were thinking, are we going to treat her coronary arteries? And are we going to do that before the valve? Are we going to do a left main stent? They were all calcified. Are we going to have to do rotational atherectomy? How are we going to get her through that procedure with a valve that's critically stenosed? And we talked about this for a long time, and we ultimately decided, let's just do the valve and see how she does with the coronaries. And more in patients who are really high risk, we're treating the valve and leaving the coronaries. And that's something we were scared to do initially, but we think it's safer now. So. Yes, Dr. Sutherland, last question.
What portion of the TAVRs are now getting embolic protection devices in place, and where do you see that going?
Yeah, I've got a meeting with Dr. Ostrin coming up in the next week. There's a bit of a cost-benefit analysis that needs to be had, and I think so. We're sorting that out. I think we need to have it available to our patients, but it's tough to. You can't predict who's going to have a stroke, so how do you decide who gets it and who doesn't? So my personal opinion is that we need to either employ it universally in patients who are anatomically suitable, or just make a decision as an institution that the data isn't there to support its use. And so I'm going to state my case, and we'll see where it falls.
Maybe you should ask Dr. Ossaran what he would like to have if that were the case.
I'm going to bring you with me. Yeah.
All right, but I was just wondering, for the TAVRs at this point, what proportion of patients have a symptomatic valve versus ones who maybe have echo findings of critical stenosis? Sort of, if everybody is already considered symptomatic from their valve for these procedures, or not necessarily?
Yeah, so I think that the only reason to do it would be if somebody does have symptoms. Occasionally we'll get somebody who has a very critical stenosis. Symptoms are tough to tease, especially in an older population who might just think, oh, I'm getting older, and mom doesn't do as much, and she just wants to read the paper. And so we spend a lot of time trying to tease that out. Is this, you don't notice that your functional quality has gone down? We do a 6-minute walk test in clinic with everybody. We do grip strength. We do frailty testing. If somebody walks into clinic, though, and says, I've got severe aortic stenosis, and I have played 18 holes of golf every Monday for the last 3 years, and that hasn't changed, I say keep playing golf. But sometimes people don't notice the changes that they've had, and we can put them on a treadmill sometimes and sort of demonstrate that they're not doing as well as they thought they were. But truly asymptomatic aortic stenosis probably doesn't need to be. We watch them. We're not going anywhere. And so sometimes we'll say, okay, we'll see you back in 6 months, and we'll see how you're feeling over 6 months. And if we need to do it then, we can do it then. But they're not going to fall off the cliff, most likely, if they're not having symptoms.
Great. Well, we'll write down a clock of great interest, obviously. Thank you very much.
Thank you, guys.